Okay. Cool. So this case is an older poodle. Alex, correct me if I'm wrong, because you may have sent me the message, but I haven't seen it. I kind of somehow guessed that the dog was coughing, had lethargy, and had reduced lung sounds. Correct me if there is anything to add to that.
I think that's right. I can quickly double check. I was wondering if you wanted to know all these secrets.
Anyway, so, and then this is the set of radiographs. And this is an interesting case because I think we have results and then we have also a CT, then to kind of, let's say, clarify, or we'll see where we go with the case, but then we will have another modality that is going to clear up all the questions, if there are questions. Maybe we are so good that we can figure out what's going right away. So take a look at the images. I think I'm giving you the best I have. Yeah, so both, maybe we go like that one. This one seems to have a better exposure. So we go with that one. Oh, come on. That one, and then this one here. Cool. So take a look, and then we do as usual. You start giving me your findings. Then we argue if we are all agree with the findings or we disagree with the findings, and then we try to explain them, make up a story. And then I think I forgot to have a pen. Bring a pen. No, I'm all ready.
Okay, I don't see an intact diaphragm shadow.
Okay, good.
Which can mean one of two things: it either isn't, or there's a lot of fluid in front of it.
Okay, I like your. Yep.
The liver does seem to be in position, but in the where are we? But in both lateral views, there's a what looks like a solid organ there. The heart shadow is globoid. There's a bit of a tilt down in the trachea there, but there's also an unexplained radio dense area there. On the VD, it's hard to determine that because the VD is looking from ventrally to dorsally, and there's too much obstruction to be able to see that last one.
I want to come back to your comment about the trachea. What is wrong about the trachea?
I get the impression the corona has moved forward.
Okay.
And that's possibly causing what appears to be, a straight trachea with a downward bend at the end.
Okay, good. So I think I agree with you. If I'm not wrong, the tracheal bifurcation should be at the level of the fifth intercostal space. I think it's fifth or sixth. So if we go 1, 2, 3, 4, 5, 6. So I think my impression is also that it's a bit cranially displaced. Pretty strictly speaking, I need to double check that. Remember that number. Based on that, I think, yeah, probably it's a bit displaced. I kind of share that. It looks like displaced. And also, I agree with your comment about, like in a normal dog, we usually have this airway. We can kind of continue that airway, which is the principal bronchus, because it's both to the caudal lung lobes. and it's hard to see in the lateral projection, then we need to figure if we can see them in the DV projection. Okay, good. So basically, if we want to argue about the trachea and the principal bronchi, we are talking about a displacement problem. Yeah. And then I also wanted to come back to your comment. I remember when I was more involved in the teaching, and in particular, I wouldn't let this go with a resident, but I remember even celebrating with the students, like not being too concerned about the vocabulary or the language that they use. So I remember even inviting them to just say is black or white or things like this. So then they concentrate in what is wrong rather than in concentrating in saying it right. But so based on that, I think it's perfectly fine to say I don't see the diaphragm. That's a perfectly fine thing. But technically, we come back to that concept, which is a very important concept, which is the concept of border effacement or silhouetting, which is the grapes with fluid concept. So, and based on that, I like your comment. So is either gone or there's something more fluid. I would add that there's not only the situation, so they could be fluid, but also there could be something soft tissue not being only fluid. So that's so when there are two soft tissue structures, one next to the other, being fluid or a tissue, then we have this phenomenon. And then probably I would add that the same thing that is happening with the diaphragm, I think you mentioned that, is happening with the caudal contour of the heart. So if you're writing a report, you can just write this in a very simple sentence and say that there is effacement of the caudal contour of the cardiac silhouette and the cranial contour of the diaphragm. You are just using that concept word somehow. Okay, very good. I completely agree with that. Okay, what else? I probably shouldn't say a lot that I agree, so I let the opportunity for others to disagree. So sorry about that.
I think in the second lateral, you can see a loss of detail in the abdomen, and looks like some cranially displaced bowel loops. I don't think the two, I'll just put it on the screen. I don't think this is stomach. Here, I think that gas there is bowel, and it looks like it's a little bit too cranial. And yeah, I don't see, maybe that is stomach, but I don't see the stomach, the gas looking normal in the stomach, whereas on the DV or on the VD, it's reversed. So this is the gas I would normally see in the cardia or the body of the stomach, but that looks normal on the VD. Maybe you have some additional.
That was,
thanks.
Yeah, sorry.
That's good. And then you also have you can see even clearer now this extra little bit of gas over here, which looks in an unusual position for if it's small intestine. And I can, this gas, maybe it's the cecal folds, but it's quite distended, but maybe it's just normal cecum. There's a few other things happening in the chest. There's some, I think there's pleural fissure lines. I don't know if I can see it on the current view, but I can't find the pleural fissure lines now. I thought I could see some pleural fissure lines on the other in the keystone. And I'm just interested.
You can see them on the lateral. I'm with you.
You can? Yeah.
I can't point it out.
And I'm interested in this. I'm wondering if it's one of the crura of the diaphragm, but I don't know what it is, but it's the soft tissue opacity that sort of parallels. It would be, if it is a crura of the diaphragm, it would be displaced cranially, but you can still see, gas in the lung behind it, it's cranial to it in the same, it looks pretty similar, so maybe it's not a diaphragm cruise.
Okay, okay.
And the heart,
So,
yeah, trachea is elevated, as we said before.
okay, okay. So the trachea we add, there is not only cranially displaced, but it's dorsally displaced. Okay. Then, can we have anyone trying to identify or showing where you think there are the superficial lines? I think I agree with you, but
I'll have a go if I can annotate. Hang on, see if I can do this. Draw. I'm not as good as everybody else at this, but I'm going to go on to the first lateral, and I haven't got a right left marker on there. But I think when I'm looking at your pictures, Mariano, I can't enlarge them. So if I go at the link, I can, but I can't obviously draw on that one.
which
So I
one do you
can't-
want me to magnify?
The top left. Yeah.
Is that okay?
Okay.
Better?
Yeah. So we've got fissure lines coming down. And then you can see what I think are the edges of lung lobes. Down there. There's probably more. I think there's probably another one. I think there's another one there, actually. So do you not think those are fissure lines?
No, well, I think there is pleural effusion. I think I want to warn you. So this is excellent. So I think in this particular case, I think this separation of the lung from the wall, another word that we use for that is scalloping. So it's kind of the leaves. And when they separate, when the lung separates from the wall, then we see that border. So I think you're right in this case, but I need to warn you that I will probably not trust on those all the time. And the reason for my suggestion in kind of being careful using that feature is because if there is fat in the mediastinum, it's going to act in the same way. So if you have a fat dog, there's going to be that separation of the lung from the wall, and then you kind of confuse it with pleural effusion. So that would be the feature that I would trust the least to see if there's pleural effusion. So
Okay.
probably I would. So the line that you're showing there, and then after a while you kind of memorize where they should show up. So for example, I would pay attention to this one. So that line up there is always in that position, and then I would trust that one. And then I'm not 100% sure about this one. Probably I'm more confident about this one. And then, so the idea there is that now if you find that soft tissue structure that is separating the two lobes, so it's not in between the wall, the ventral wall in particular, and the lung, but in between the lungs, then fat usually doesn't go there. Make sense? So it goes ventrally, so you can't separate the lung and it push the lung dorsally. So then fluid or fat can do that, but in between the lung lobes is only fluid. So if you see that separation, so that's the principle trying to go there.
Yeah,
I would personally probably go like, in this particular case, I think the easiest way to be confident about fluid is in this projection and see that separation here. So it's not that the lung is not that much separated here, and then it comes in a little bit. It's kind of rounded contour. So this is already abnormal. It should be a very straight line. And if you go here, it's even worse. So there's a clear separation of the lung here from the wall. So I would probably use this. I think there's a pleural fissure line there, and then this is the place where we want it, and I think there is another one there. And again, so this is a mixture. You can say, well, I show you a way larger line, and now you're confident based on a smaller line. So probably what I would answer if you have that thinking process, it would be that I know exactly where the pleural fissure lines should show up anatomically in a DV. So then I'm more confident when I see something in the right place, even if it's small, rather than something that looks like something like a pleural effusion or pleural fissure line, but it's actually in the wrong place, or it's in a place where it is not usual or the usual anatomical location. So here again, I think I'll be very confident. separation of the lung, rounding of the contour. So I think you have a lot of evidence. And then the other evidence that I think is probably a bit more difficult in this case is that we have the silhouetting. So when this is a DV projection. So when fluid accumulates ventrally, then the way that we see that, when there is a small amount of fluid, then we don't see the borders of the heart because the fluid accumulates there. If you turn this dog around and now you have a VD, now the fluid is gonna kind of sit more in between the lung lobes, and then the lower facial lines are gonna look a lot more, like a lot thicker and a lot more clear. So be aware, when there is a bit of fluid, be aware that the positioning has a lot to do. So in a DV, you expect not so much superficial lines, you expect the silhouetting. In this case, it's hard because the silhouetting may not be only due to fluid, there may be something else. And then in the lateral projections, I think I would probably buy this line and this border, probably this one, and then this one up here. But it's good. I'm just going thin, you know, but I'm taking the opportunity to just make those, whatever, I'm thinking aloud. And then, yes, let's see if you see something else that is interesting in this case. Or let's continue with the findings.
What I described as a solid organ structure that eventually there is probably just a contrast with an airfield structure here, I wonder.
Okay, yeah, I agree. Okay, yep. So, sorry, this gas field structure, I think, is probably lung. Makes sense because it's either lung or pneumothorax. And yeah, I agree that it seems to be against something soft tissue. I agree.
The other thing I was thinking, and I might be on the wrong track, but it's hard to assess the true cardiac silhouette because of the border effacement. So it's hard to make a call about whether it's enlarged or not. So I tried to look at the vessels on the VD. I can't really tell because I think it might be a bit underexposed at that level, but from what I can see, I think that the vessels seem okay. So it makes me think that a heart-related change is less likely.
Cool. So you are trying to gather indirect information. So that's perfectly fine. So in this particular case, and I think if you point, I think it's very good that you point, or at least try to find the vessels. And I would add not only the vessels, but the airway to the caudal lung lobes. So if we go like that, I think this is the bifurcation, and I can see one, which is going to be the right there, and that's going to be the artery, which is relatively clear, and that's the vein. And then similarly here, this is the left airway, and this is the artery, and that's the vein. So remember that we compare with the 9th rib, so 13, 12, 11, 10, 9, and then we compare. So where it crosses the rib, it should be like a square thing based on the size, and then the artery and the vein should be more or less the same size. So all of that is looking okay. So even including the airway, so that is telling us a lot of information. It's telling us that your indirect information about the heart, but also it's telling us that that lung, at least the lung that is surrounding those vessels and that airway is aerated. Otherwise, we wouldn't be able to see the vessels. So very good point. And then probably I would also add, because now we are thinking about pleural effusion, and if you want to extend this indirect thinking or trying to catch evidence, then to look at the abdomen and see if you think there is fluid in the abdomen, which someone already mentioned that there may be a bit of reduced serosal detail, but along the same lines, you can always gather information, indirect information about the heart, looking at the lung and the vessels, but also looking in the abdomen and the size of the liver, for example. So right and left. Okay, anything else?
I came in late, so apologies if someone else said this, but it's got sort of the characteristics of a lung mass to me, with like the rounded edges and it's like within the thorax. And on the VD, it doesn't look like it's very lateral, so it would make me wonder if it was the accessory lung lobe based on location.
Okay, well, so now we are moving into trying to explain what we are seeing. So but that's perfectly fine. Before we go there, and then we try to see how many ideas we have and which one is the best fit, I wanted to point to something else, which is this line here. Have you seen that? I saw it when I was looking at the pleural effusion. So that's the place, that's the separation between two lung lobes. So that's where we look for pleural effusion. But then I saw this. There's kind of a relatively well-defined soft tissue opaque line, kind of with undulating contours, and it's also here. So any guesses about what is that? It's just a curiosity, but it's good to talk about it.
Is it some kind of mediastinal line of some sort? I don't know what.
But I'm just gonna say it and we move on because it's unrelated. So there was have you heard about the plate-like atelectasis? So it's like a cool thing to, and it's apparently very common in human medicine, in radiology. And there is a relatively recent paper where I think they went through CTs and radiographs, or I don't know how they could prove it, but they kind of introduced this. And this is exactly how it looks, and the location where we usually find it, and it's completely irrelevant. It's just a little bit of lung that is a bit of atelectatic, and it has the shape of a plate, and it's usually there. So based on the appearance, opacity, margination, and location, I would say that that's a plate-like atelectasis, which usually we don't care about. But just to mention, by the way. Okay, so now interpretation. What do we think is going on? Lucy, you already suggested that you think. So correct me if I'm wrong. You think there is a lung mass, and you are doing that based on the borders that you can make something rounded, and then based on the location, you think that that mass with rounded contours is located in the accessory lung lobe.
Yeah.
Is there any other interpretation, differential? Anyone disagreeing with that? All agreeing with that?
I'm not sure of the location where we're talking about at the moment.
Oh, so Lucy, do you mind showing where you're talking about?
I think it's like they're into somewhere down the bottom. You can't really see the bottom.
Okay.
They're same situation. I sort of thought it was going to be somewhere in this white out in the middle. I think this is the heart at the front. I don't think that's the mass. I think it's going to be somewhere in the middle, but there's nothing on the sides, which makes me think it's not like the left or right lung lobes. Yeah, that's what I got. I guess it could be heart. It could be a heart mass because we can't see. Like it's got effacement, so it could be a mass off the heart, but it's a bit of a weird. Like it's really big for a heart mass, I think. Don't know. That's what I got.
Cool. Thank you for drawing and explaining where exactly do you see the mass. So for the rest, do you buy that? If you don't buy it, do you have another option? Do you have a differential?
One thing, I can't really see the mass, but and it doesn't explain what it looks like an increase, some irregular increase in opacities here, which are greater than soft tissue opacities. That's just dorsal to where Lucy was, just ventral to where Lucy was circling. I don't know if what that increased opacity is there. they're not on the rib line, so I don't think they are. It's ribs. That Lucy's theory of the mass definitely could explain what looks like a cranial displacement of the heart. It looks like it's way too far cranial. So something I would say is pushing it forward, either from the abdomen or within the chest.
Okay, good. So I think I agree with you. There seems to be areas of kind of ill-defined, poorly marginated areas of mineralization in here. I agree with you that it's hard to see them here. So, but we don't see them outside. So it's like, oh, maybe there. So then they seems to be sitting within what Lucy pointed out. So it's kind of an area of mineralization. I think we could use that to narrow down the list of differentials. So yeah, very good. And yeah, so I'll grab your sentence that if there is something there, then we can explain the cranial displacement of the heart. I would add that if we position a mass, I'm not saying, I'm talking about a mass as a concept of a space occupying lesion, which then we can try to figure out what could it be. But I'm just talking about more very generically about a mass. Then we can explain not only the displacement of the heart, but we can also explain the effacement of the border of the heart and the effacement of the border of the diaphragm. So basically, we can explain everything that is happening by putting a mass in that. If you want to divide in quadrants, the thorax, then we are talking about the caudoventral quadrant and kind of on the midline, because I also like Lucy's comment that it doesn't seem to be centered laterally. Probably it's more on the left, but it's probably sitting more in the center. So do you have differentials for, so if we can, this is the idea of trying to summarize when we look at things. So then it kind of opens up, it's easier to think about differentials. So a summary in this case would be a mass with mass effect, or you can just say a mass in the caudoventral thorax with areas of mineralization and pearl-effusion. So now you can even close your eyes and say, well, what are the options? You know, how can we end up with a mass in that location?
I think we're still open to a hernia, aren't we, as well?
Okay.
So
good,
it could
good.
be a herniated piece of liver that may have become mineralized, maybe a cancerous growth that's extending through the diaphragm. I don't know whether we're talking about an intrapericardial mass here. I don't think so. I think we're saying that it's not, because if it was intrapericardial, I think you'd see better definition of the diaphragm. You wouldn't get the same effacement. Or yes, I guess you would if it was, sorry, I'm going to take that back. I'm going to take it back. Or else you've got a caudal lung neoplasia, or you've got abscess. An 11-year-old dog, it's far more likely to be neoplastic. That's
Weird
Okay.
location, but lung lobe torsion.
Okay, so it's good. So we are now being creative. So we said hernia, and it's very good to put everything, even then we can remove it easily. It's good to be creative and put everything. So hernia, we talk about a lung mass, then we open that up. It could be an abscess, it could be neoplasia. Then we said it could be a lung lobe torsion. Then there is always coming back the idea of a heart mass. Okay. Anything else that you want to add?
Could you do, it's probably not because it's bigger, but something that would just consolidate the lung lobe, like a foreign body or something like that. But it would, I guess you wouldn't expect it to get bigger. You'd expect it to get smaller, maybe. Don't know.
Well, that if you push that idea, then you can end up with atelectasis, and then the differential will be probably if you push it even longer, then you can have an abscess.
Yeah.
So if you obstruct the airway, let's think about a foreign body, then that could go with pneumonia, atelectasis, and then down the track you can go to an abscess. So we go into the lung mass situation which also could be a granuloma.
Mhm.
Yeah.
The hernia idea
I'm
is very
thinking if-
tempting, but what intrigues me though is the 11-year-old dog. Admittedly, hernias can be chronic and never found until post-mortem, but there's no evidence that I can see of any fractures or healed fractures, which I might have expected if with a trauma severe enough to cause a hernia. And as for a congenital hernia, like a pericardio pleurodiphragmatic hernia, if that's the correct term, my understanding is that they're more often congenital, like in Persian cats. This isn't a Persian cat. And
Yeah. Okay, good. So now we kind of slowly transition into the, let's pick all of these options and see if it fits or if they fit or don't fit. So let's take the hernia idea first. So for the hernia idea, I think the location is a very good location. So what are the things that fit? The location is a perfect location because if the ventral part of the diaphragm broke, either a diaphragmatic rupture or a true hernia, congenital, then that's the perfect place. What it doesn't fit is that we had a little bit of a discussion about the positioning of the stomach. So I think I feel confident saying that that's the fundus of the stomach. And I understand why this is kind of hard to be confident about the position of the stomach, because our brain relies on that border of the diaphragm to judge the size of the liver. Makes sense? So we reference the cranial contour of the diaphragm and then the position of the stomach, and then whatever is in between is going to be the liver. And now we've lost this reference. We've lost that border. So it's kind of very hard to judge. But the way that I will go is, I see the fundus here, and it's within the rib cage. And then I know that in a normal, so if the liver is normal in size, then the pylorus should be more or less in the same intercostal space. And if I go here and this is the pylorus, then the axis of the stomach is okay. So then I don't think there is a lot of displacement. This is probably the ventral contour of the liver. So it goes even caudally to a rib cage. So I personally don't think, even though probably the evidence is not overwhelming, but I don't see any evidence of, do you remember that we had the indirect evidence of hernia? And that was the displacement of stuff. So in this case, we have the displacement of something in the thorax, but we don't have the displacement of anything in the abdomen, I think. So then, and then it's also an older dog, and we have the mineralization. So I think we need to really push this idea, even though probably we can't rule it out completely, but I don't think it's a perfect fit. So that's, if you disagree, let me know if you want to argue against that. So the other thing that I probably take now is the hard mass. I think hard masses are very uncommon caudal, let's say caudal to the tracheal bifurcation. We had a couple of examples already where we saw a chemodectoma. Do you remember? That was sitting here. Then we had a case of I think it was a right atrial mass with a lot of pleural effusion. So then it would not look like a mass separated from the lung. It would all look like a big ball, like here, like a baseball or a football image of the heart. We don't see that. It seems the mass seems to be caudal to the bifurcation, which I'm not saying that it's impossible. You know, weird things can appear, but it's a very uncommon situation for a hard mass. So again, I don't think I would feel that I can completely cross this out of the list, but there's a big but in there. You know, it doesn't. There is one thing that doesn't really fit, which is the location. So that for hard mass. Then for lung lobe torsion, I think the odd thing is that the lung lobe. So the accessory lung lobe, I don't think I ever came across like a description of a lung lobe torsion affecting that lung lobe. So again, it can be the first case in the literature, but again, it's an unusual lobe. So out of that, I personally would like the idea of this being in the accessory lung lobe. I think it's a must. I think the reason why we don't see the clear borders of the mass. We see some borders like this one dorsally, and laterally it's quite hard to see borders, but dorsally we see there is because it's sitting in the center, in the midline, and is in contact with a lot of soft tissue structures, different from a mass in the caudodorsal lung lobe, which is the classic appearance of a mass surrounded by lung. So this mass is not all surrounded by lung. A lot of the mass is against the heart, a lot of the mass is against the diaphragm. That results in border effacement. And the only border that we can confidently see is the dorsal one, which is the one that is against the lung. So this will be my thinking process. And then in terms of what it is, I think the mineralization and the fluid and the age is probably helping me to put this as a top differential, neoplasia as a top differential. But I think another differential could be, well, could it be like a foreign body and then this turn into a granuloma? Yeah, it could be. The accessory for that, the accessory lung lobe is a possible one because of its ventral. So if there is something with some weight in the airway that keeps traveling, it could go into accessory. And so this would be my thing. So based on that, I think it's in the lung. Based on the age, mineralization, pleural effusion, I think it's likely neoplastic. I think other differentials are less likely, but a granuloma would work. And then I think a lot less likely we have the idea of a hernia with an abnormal liver going across. And then I think it's very unlikely to be a heart mass, again, based on the location. So this will be my thinking aloud. I kind of took over for a minute because I wanted to show you the CT. So do you want to add something to this or disagree or? No? So let me show you the CT. And now I sound like extremely confident, but obviously if we run a CT, it's because we hadn't felt that confident. There was we need to be a bit more confident. And then the idea of running a CT and having endogo and anesthesia was not only to confirm, but also to plan like a biopsy, how to access that. So CT can help with both things. So soft tissue algorithm with contrast, kind of a lung algorithm, and then we see, I don't know if this helps. I can do a reconstruction if you want, but basically, let me do a reconstruction because I think it's going to be a lot easier. And then we get this one. So you know where we are. Okay, good. So okay, so short axis or axial here, then sagittal here, and then dorsal here. And now it becomes a lot more clear where the mass sits. See, so it's kind of ventrally there. It extends a bit more, sorry, to the left. That kind of wraps around, and I think it also compresses the column vena cava. So if you go here, we follow the column vena cava. This is the column vena cava going across the diaphragm, and then the mass sits to the left. This is exactly where the accessory lung lobe sits. This is a bit of accessory lung lobe that then turns into an abnormal mass. See, there's obliteration of the airway, and there are those areas of mineralization there. So I think this helps a lot to confirm that this is accessory lung lobe, because we can follow the airway, in particular to the accessory lung lobe. It's enlarged, it's very disorganized, has areas of mineralization. Then we can also confirm that it's not the liver going across. So then the differentiation between the liver and then the mass is very clear, and we can go through and then kind of make sure that we are not confusing that. And I think we can, in the same way that we can now, the CT help us differentiate the mass from the liver, also help us differentiate the mass from the heart. So we see contrast there in the left atrium, left ventricle. And again, I think it's really supportive of a mass in the accessory lung lobe. And then it also can help us plan like a biopsy. So there is a place where the mass is in contact with the wall without the interference of air-filled lung. So that's what we've done, and we've taken an FNAs of that mass. So that's the story of the case. Do we have the results?
Yeah, we do have the results of the FNA. Let me just bring it up.
I can do it.
Oh, cool. Thanks,
sorry.
Anna.
So the FNA was a pulmonary carcinoma, but with a lot of inflammation surrounding it and suspected bacterial infection. So suspect the mass is primary, and then that's caused a bit of stasis and mucus and predisposed to infection developing down there. This dog, we put this dog on antibiotics because it had become quite acutely unwell. So we thought it was symptomatic for its pneumonia, but it didn't respond very well to antibiotics and was euthanized a few days later.
Good.
Wow.
So I think the whole thing about having the cool radiographs, CT, and then the histopathology or the pathology, it makes a nice case. Kind of the take-home message, if we come back to the radiographs, for me, it was nice to share again another example of a lung mass that is not easy. Makes sense? I remember showing you a lung mass, and the classic one is the one that is well defined, is surrounded by air, aerated lung, usually in the caudodorsal lung field. That anyone can do the diagnosis. Last time we had a mass that I think was bleeding or was oozing fluid, whatever, and resulted in a lobar pattern. So an unusual presentation. It's still a mass, but it's kind of the exception to the rule. And then we have the silhouetting. Makes sense? We have the mass. If the surrounding lung, instead of being aerated, now is fluid filled, either because the mass is bleeding or there's obstruction of the airway or whatever, then we don't see the borders of the lung. And then a lung mass, which is an easy diagnosis, turns into a very difficult diagnosis. And this is another example. So that's why I love the case, because I think there is a continuity with the case before. This is another lung mass, but I think rightly so. When we first saw this one, no one really jumped right away and said this is easily and obviously a lung mass. And the reason for that is because of the location. It's in a place where, most of the borders of that lung, first, is sitting on the midline. So unusual. In the midline, we usually think that there's the mediastinum, and then this is an exception to the rule. The ventral part of the mediastinum doesn't sit on the midline. On the midline, caudal is the accessory lung lobe that sits exactly on the midline. So that is one difficulty. The other difficulty is that this mass is against many soft tissue structures, so it's erasing most of the contours, and that adds complexity. And then for a similar reason, based on the location where the location of the mass, I think differentials like hernias are welcome, and heart disease or something that we haven't mentioned. I don't think there is a lot of evidence, but in theory, we should be thinking about that as an option. Is a thoracic wall mass, could it be coming from the sternum? If you look at the sternum, there is no lysis, new bone formation or anything. So I think it's unlikely, but that would be another option.
Random question. Do you ever get masses of the diaphragm?
Very unlikely. I think they are mentioned.
But really unusual. I've never come across it.
mesothelioma.
It's like, is that a thing? I don't know.
So I think if you go back to the book, there is always a mention about, a diaphragmatic abscess or a mass. I don't think maybe I've seen it and I never diagnosed it, but no. So for me, it's a lot easier. So if I see a mass close to the diaphragm, then I can give you a long list of possibilities. So could it be a hernia? And then hernia, you have like 20 different flavors, and we saw some. Remember that we saw a hernia through the foramen of the Calvina cava. We can have a hiatal hernia. we can have a true hernia, like in this case, it would be like the ventral aspect of the liver. We can have a diaphragmatic rupture. So all of that, those are options. Now, if you go on the other side, could it be pocketing of fluid? So could it be like a biothorax, where you have like a pocketing of fluid against the diaphragm? So that would be an option. And then the other option would be, is it the lung? Is it the wall? So I would think about all of those options, all the neighbors of the diaphragm, also the diaphragm, but in my eyes, it's a very uncommon. Again, it's mentioned in the book and we list it as a differential. I don't remember seeing like a focal lesion like this coming of the diaphragm. I suppose it could be a leiomyoma, leiomyosarcoma coming from the diaphragm, but I've never seen it. I think in the book, there is the mention of granuloma, for example, coming from the diaphragm, but I don't remember. I wanted to show you this, which is a little bit of anatomy. So when we call the mediastinum, mediastinum comes from the middle. So we have this idea that it's in the middle, and it is in the middle if you go on the dorsal mediastinum. So this is a sagittal view, it's a CT. So if you go dorsally at the level where you have the esophagus and the trachea, then the mediastinum is sitting on the midline. So then the lung on one side, lung on the other side, and then we have the structures that we know are sitting in the mediastinum, sitting in the middle. Now, if you go more ventral, then the mediastinum, the heart is in the mediastinum, but then in the midline, there is lung. And caudally is the accessory lung lobe, and cranially is the right cranial lung lobe that goes across the midline. So the diaphragm is pushed to the left, more cranially, and caudally we have the mediastinum is divided in two. It's divided into the mediastinum wrapping around the corvina cava, and it's also divided in the mediastinum going from the wrapping around the heart and going to the diaphragm. So basically, there is a line where we used to call it, it's a reflection of the mediastinum, but we used to call it like a pericardial ligament that comes in this way. But in the middle, I insist, is the accessory lung lobe. So be aware of that, because something sitting in the midline, if it's more ventral, it may not be in the mediastinum, it may be in the lung. Makes sense? So that's a little bit of an anatomical thing. Okay, so here in a radiograph, I want to show you this. So this line is the actual mediastinum ventrally. Dorsally is on the midline where the trachea runs, but ventrally, the right cranial lung lobe goes across the midline and pushes that mediastinum, and that's the line. So that's the mediastinum. That's the reason why sometimes we see the thyroid or the thyroid remnant here, a little bit to the left. And here on the more caudally, again, dorsally, the esophagus is going to run here on the midline, but more ventrally, we have the corvina cava that is to the right, and we have that reflection of the mediastinum to the left. So if you have a mass sitting here, like in our case, even though it's in the midline, if it's ventral, it's likely not in the mediastinum. Okay, so the thyroid there, and then, yeah, that's it. I think I wanted to show you one more thing. Okay, so what are the features of a mediastinal mass? So this is interesting. So the mass lies on or adjacent to the midline, or the mass is in a position consistent with one of the cranioventral or caudoventral mediastinal reflections. So this is in the book. I remember seeing this case and saying, well, this confirms that line in the book. This is a good example to show this, which is a little bit of an exception to the rule. I kind of enjoy those. That's why I usually pull those cases. And then the other feature is that there is a deviation from mediastinal structure. In this case, this worked as well, which is a deviation of the cardiac silhouette. Okay. Any questions? We have 5 minutes. It's a beautiful case. I don't know if you like imaging. I will probably, if you want, I can post the CT So then if you enjoy imaging, what you could do, maybe you need to be a fanatic, you know, to do that. But if you like imaging, you could, after all this conversation and all the drawings and all the talking, you can come back and see if you really see the things. If you don't see things, or there are things that are in the air, not clear, then this, I suppose, could be a very nice trigger to go to the book. And then if you want, I can put the CT, and then you can also try to see, you know, things that you see or don't see in our area, how they look like in the CT, and try to make up, you know, build that image or that structure or abnormal anatomy in your mind. I don't know. This would be for those of you that really enjoy imaging. That would be the next thing to do, to keep on learning, and in a more quiet way, let's say, so without the pressure of saying something in an hour. So we back and forth. And then you can always ask the next time. So if there is something hanging there. Okay. Are we done?
Yeah, good case. Thank you.
Yeah, thanks, Mariano.
Yep, thanks. Very interesting. Okay.